I'm going to talk about like minimal access for adult spinal deformity. Here are my disclosures. So we're going to go over just the overview of some of the surgical goals of MIS deformity correction, talk a little bit about the literature that's out there right now, and talk specifically about the technologies that enable us to actually perform scoliosis surgery through MIS techniques, then finish off with a little bit about the future of MIS. So scoliosis, as you know, is a Greek term, means obliquity, bending. It's an abnormal curvature of the spine, not only in the coronal plane, but also in the axial plane as well. And as we know, in the sagittal plane, the amount of sagittal balance that you have is obviously very, very important. So for MIS scoliosis surgery, all of the goals are the same as open surgery, especially the top 5. So as you know, to correct and stabilize progressive deformity, improve and restore the coronal, sagittal, and axial balance, obtain a solid fusion, decompress neural elements. And this is one where I think that MIS surgeons really need to focus a lot on prior to even doing more complex cases, relieve pain, and finally minimize complications. So this is a study from Chris Howe from Harborview that was published in Spine in 2011. It was a retrospective analysis of over 100 patients that had surgery from thoracolumbar to pelvic. And then so they took a look at their results and looked at the complication profile for these patients. They had a 4% mortality rate, mean hospital stay of 12 plus or minus 7 days, as well as mean ICU stay of 2.7 plus or minus 4 days. But the results also showed that there was a very significant percentage of at least one major complication, at least 12% of one major complication. 17% had new persistent neurologic deficits, and 35% underwent at least one unplanned return to the OR. So at least a third of these patients had to go back to the OR, and that was unplanned. So their conclusion was that complex spine reconstruction involving fusions from the thoracic spine to the pelvis continues to be high risk, in spite of more advanced surgical and perioperative techniques. And this is I think this is one of the landmark studies that takes a look at the differences in infection rates, looking at open versus minimally invasive techniques. It's a retrospective review of the Scoliosis Research Society's database of over 100,000 patients. And the results show that when they compared open versus minimally invasive surgeries, there was almost a 3x difference in the difference of infection rate comparing open to minimally invasive. When they took a look at fusions and they just looked at T-lifts, they found that there was a greater than 2x difference in open versus minimally invasive surgery. And as you know, the SRS is an open spine surgery. It's not necessarily an MIS society, so this was actually very eye-opening. So the Scoliosis Research Society's conclusion was that there's about a 2 to 3x decrease in the risk of infection when comparing open versus MIS. This is a more recent study that's coming out of Northwestern from Tyler Koski's group. It was a retrospective review of over 200 patients undergoing MIS scoliosis reconstruction. And they found that MIS scoliosis surgery resulted in lower number of levels that needed to be fused, shorter surgeries, which is really interesting, shorter length of hospitalization, less likelihood of being admitted to the ICU, and if the patients were admitted to the ICU, they had shorter ICU stays. And I'm thinking that all these make sense except for maybe the shorter surgeries, and this may be because they may have actually overcome sort of the learning curve for MIS. So there is currently a paradigm shift occurring in spine surgery, and it's occurring relatively slowly, I would have to admit, but a lot of people are adopting minimally invasive techniques, and I would also say that going from open to mini-open to tube-based and even endoscopic, that's sort of a transition into it. And even doing laterals, that's considered minimally invasive. But MIS really, it's been shown to decrease the morbidity associated with open procedures, decrease postoperative pain, improve clinical outcomes, shorter hospital length of stay, reduce utilization of services, which really equals lowering the cost of care and increasing the value of the surgeries that we provide. And I think a lot of this is really being really verified and validated in the literature today. So we utilize technologies like high-powered microscope to allow us to actually get access to areas that we are using through smaller, less invasive portals, such as a tube. So you can see that this is an example of a tube decompression. And now you can really perform all types of procedures that address stenosis, whether it be central stenosis, lateral recess stenosis, foraminal stenosis, or extraforaminal stenosis. And it doesn't matter if it's in the cervical spine, thoracic spine, lumbar spine, or sacral spine. You can actually access it through less invasive techniques now. So this is sort of the advent, I think, of endoscopic spine surgery. I'm just starting to do these, but if you take a look at areas like Europe and Asia, it's really becoming the standard of care. And I think this is sort of the direction that we're going to be taking within the next probably 5 or 10 years. And because of the technology, including fiber optics and great high definition and resolution of even the screens and the cameras that we're using, we can get into areas that we typically could not have gone to, even with open procedures. We can also now perform more complex procedures, meaning that what do you do about removing hardware that's already been placed either by the same surgeon or a different surgeon? But there are techniques now where you can actually utilize minimally invasive techniques. So this is a sort of a laser-guided approach where you go down the shaft of the screw itself, and then you place a guide wire right down that coaxis and put that guide wire on the screw head and then dilate over with the screws. And once you do that, you can actually get right over each one of these screw heads. And then once you actually utilize high-powered microscope and magnification, it's just like doing any other hardware removal. Take out the set screw, you take out the pedicle screw, and then you take out the rod. But what I want to talk about today is MIS scoliosis reconstruction, and I want to sort of highlight that through two case presentations. This is a 66-year-old female. She has a history of chronic low back pain and left thigh pain and progressive left-sided lumbar hump. She was hunched forward on clinical examination. She actually had a pain pump placed by a pain anesthesiologist. She was pitched forward 20 centimeters and right 13 centimeters. She had a 47-degree left apex thoracolumbar curve and a 75-degree thoracic curve, or thoracic kyphosis, that is. And clinically, this is what she looked like. She was bent over to the right. She actually had sort of a flank fold over to the right, but it really was her sagittal balance that was really giving her a lot of problems. She was pitched forward and had to hyperextend her neck in order to look forward. This is what she looked like when she bent forward. She had a pretty significant, what appeared to be left thoracolumbar prominence on forward bending. This is what her radiographs looked like. She had a 47-degree curve in the coronal plane, but had a 75-degree kyphosis measured from T5 to L5 with a 20-centimeter anterior pitch. So her diagnosis is adult degenerative thoracolumbar kyphoscoliosis. So the question is, can you actually approach these through minimally invasive techniques? And we stage these. If it's just in the lumbar spine or in the thoracic spine, we actually do it just through one day. So the first stage of the procedure will be done as a lateral lumbar interbody fusions. The second stage on the same day will be percutaneous posterior, plus or minus T-lifts at levels that you could not access through the lateral approach. And then we'll also do facet fusions primarily in the thoracic regions where no inner bodies were done. And so we approach it through a relatively small incision and place in inner body spacers. You can use any type of cage. It can be made out of PEEK, it can be made out of titanium, it can be static, it can be dynamic. I really do believe that the expandable cages are going to really revolutionize the way that we do surgery as well, especially MIS surgery also. So after the first stage, we start to get pretty good sagittal balance reconstruction. So we get lordosis maintained. And this is intraoperatively, and on the AP view, it looks like we already got pretty good correction of the coronal plane. But what ends up inevitably happening with these patients is that when you stand them up the next day without any hardware, so this is actually when we used to stage them on 2 separate days, we would see that the lumbar lordosis and the height restoration is pretty stable, but when you take a look at the coronal, they lose a lot of that coronal balance from what you saw in the intraoperative scans. So we stage these, as I mentioned, L5S1, we're not able to actually access that through the lateral approach, but I think now The standard for me has been TLIF, but I'm really looking at OLIF at L5S1. I think that's a viable option. I know Bob and I have been really exploring that as a possibility. And then you do percutaneous instrumentation from T10 through S1. And I think this is a really powerful strategy also, using impaction bone grafting. This is a lot like the impaction bone grafting that the total joint surgeons use for hip, like acetabular defects, when they pack it with bone and then they sort of press fit their cup. This is a very similar technique where we actually make a small annular or annulotomy and then do a complete discectomy, put in a spacer, and then either before and or after you impact bone, so you're essentially just filling the entire rest of the space with bone graft. So this is what, this was actually a little bit of a surprising case because of the fact that normally I think we would have gone from upper thoracic all the way down to the pelvis, but we ended up doing this procedure and limiting it to from T10 down to the sacrum and got pretty good correction from 47 degrees to 6 degrees. And then got pretty good sagittal balance correction as well, just by doing a limited reconstruction. This case was done at least, I want to say 5 or 6 years ago, so we actually haven't even seen her back. She may be back because of the fact that she may actually fall over at the top, but we just haven't seen that yet. So Dr. Lonstein said, in the field of scoliosis, there's one rule to observe: keep your eye on the patient and not upon the curve, which I think is very, very important. So clinically, how did she do? This is probably about her 6 to 12 week follow-up, and she was found to be doing quite well, both in her ability to stand straight in the coronal plane, as well as look at her sort of coronal reduction with respect to she had a pretty significant right flank crease, but now it's pretty symmetric on both sides. And then this is really where she got the majority of her gains, was the fact that she was actually bent forward so much and had difficulty and had to hyperextend her neck, but then now she was able to stand straight and look forward. And then this was also kind of a surprise as well, the fact that, the way I learned scoliosis surgery with Dr. Boachi at HSS, we used to routinely do thoracoplasties and take down ribs in order to take down the thoracic prominences, but I think there are now techniques that you can utilize in order to actually make it much more balanced without having to do those types of techniques. This is a second presentation of a 43-year-old, slightly younger patient diagnosed with AIS as a teenager. She had a history of progressive right thoracic and left thoracolumbar humps, worsening pain at both thoracolumbar prominences and bilateral lower extremities. She lost about 2 inches in the past few years. She had a 6 centimeter positive forward pitch, 50-degree right apex thoracic curve, and 64-degree thoracolumbar curve. She had a double major curve with a slightly positive forward pitch. And then the MRIs demonstrated evidence of lateral listhesis at L3-4, and foraminal stenosis is a very common pattern in the concavity of the lumbosacral fractional curve. And that was the reason why she was actually getting some sciatic symptoms, because of impingement of the exiting L5 and the traversing S1 nerve roots. So her diagnosis is adult idiopathic thoracolumbar scoliosis. And so we staged these on 2 separate days because we're still not fast enough to do these on the same day. So the first stage, we have one of these cases coming up this week as well. So the first stage, we do mini thoracotomies in the thoracic spine, and then we do L-lifts in the lumbar spine. So the mini thoracotomy is pretty standard technique. It's like the same type of approach that you would use in putting in a chest tube, actually. So above the rib, and then place in your retractor, do your discectomy, and then insert your cage. And then we use dual lumen intubation. So once we're doing the procedure itself, when we're actually doing our approach to put our retractor, we actually deflate the side of the lung, typically on the right side that we approach. And then once you have your retractor down, you can actually expand the lung again and ventilate, and or if the patient's young and healthy, typically they'll do reasonably well with just one lung expansion, and then once you're done with the discectomies, you can actually re-expand the lung. So this is also what it looked like intraoperatively. So the thoracic correction, the coronal plane, is not fantastic. The lumbar spine, it looks pretty good, but you can see that we got pretty good lumbar lordosis with the placement of static cages in the lateral approach. In the second stage, we typically do this 2 days later. I do it on a Monday for the first stage and then Wednesday for the second stage. And that involves an L5-S1 TLIF on the side of the stenosis, and then a T4 through S1 percutaneous fusion. And I'll demonstrate this in the lab, but typically this is one of the most important steps. So we mark the midline for the spinous processes, but then we also mark the bilateral skin starting points. And you can kind of think of these as guardrails so that you don't want to deviate too much from this line. It's just acting as a guide, but you don't want to alternate going outside, inside of this line, because what'll end up happening is these screws, even though they're multi-axial, they'll be too far out from the sagittal plane. That'll be very difficult to actually insert your rod, which is one of the last steps of this procedure. So you put a guide wire and you cannulate each of the pedicles, and typically we'll go from cranial to caudal. And you can sort of see when you're looking at cranial and caudal, oftentimes I'll take a little break and just sort of look at it either cranial caudal or caudal cranial and see the cascading effect of these guide wires. So you can see that it sort of matches the shape of the deformity. And then this is what it looks like from a surgeon's view. And then we do use powered screws, which I think increases the pull-out strength and also increases sort of the speed of the insertion of the screws as well. And then some strategies for L5-S1. For every single lumbar level, typically the starting points will be at 3 o'clock on the right and 9 o'clock on the left. In the thoracic spine, it's a little bit different. It's more like 2 o'clock on the right and 10 o'clock on the left, and we typically go a little bit more from cranial to caudal. In the lumbar spine, we try to make it parallel to the superior end plate of every single level, so it's critical to get a true AP of every single lumbar segment. And then at L5-S1, we typically take a little bit of a different approach. So we start for the S1 screw, we start a little bit more at the 4 o'clock position on the right and more of the 7 o'clock position on the left. And then we actually aim from caudal to cranial, aiming toward the sacral promontory. And then what this does is it allows the screws to actually be parallel. And it sort of it overcomes this crisscrossing effect that you would get if you tried to make it parallel both at L5 and S1. This is what it looks like when you place the screws. And this is a very powerful technique to get bicortical purchase from S1. So it's not just the lateral, because you think that the tip of that Jamshidi needle is not anterior, but in reality, when you take a reverse Ferguson, which is also in orthopedics we call this a pelvic inlet view, you can almost get like a true axial cut of the sacrum and know exactly where the tip of all of your instruments are. So you can get a pretty good bicortical purchase, which is a very effective technique to use in the lumbosacral junction. So once the screws are placed, you start seeing a little bit more of a correction, but remember, this is just screw placement without any type of reduction thus far. And the rod contouring is pretty similar to how you'd do it in an open procedure. The major difference is that you're contouring the rod to best fit what's underneath, but also you want the rod to be in the shape of the patient's anatomy after your reduction. And so now there's instrumentation that now allows you to sort of best match the shape and the 3D orientation of the screw heads, even though it's underneath the skin. And then we do percutaneous rod placement, typically from cranial to caudal, because of the shingling effect of the lamina will protect the rod from actually plunging into the canal itself in the interlaminar space. And then now a lot of the systems now have an ability to de-rotate these spines as well. So very similar to the same techniques that we use in open spine surgery. So this is what it looks like once the rod is placed, and you can see that now it's really starting to fall in line with that sagittal plane. And finally, we do compression, distraction, compression at the convexity and distraction at the concavities. We sort of map that out to make sure that we compress and distract appropriately. So we compress at the convexity and distract at the concavity. And then after you reduce all of your screws, then it really starts looking much more like a normal spine. So before, I would say in open spine surgery, sort of, you do your osteotomies, you do your releases. and then you put your rod down, and oftentimes you'll do in situ bending. But for this type of procedure, it's more in line with releasing what's tight and really fusing and maintaining what's loose and utilizing the inner body space to use ligament ataxis for your reduction. And this is the type of reduction that we can get from 50 to about 12, and then 64 to 14. And then we get pretty good sagittal restoration. So our experience has been with this two-stage procedure, average 44 degrees to 14 degrees in the coronal plane, and average lordosis of 33 pre-op to 40 lordosis post-op. Average overtime 6.8 hours, blood loss 520, average length of stay 6 days, but this is actually getting better as we get more facile at doing these. There were complications, one durotomy, one ileus, one junctional kyphosis, but no reoperations for pseudoarthrosis or postoperative infections to date. VAS averaged from 7 to 3, and ODI averaged from 47 to 27. So this long construct market in MIS, overall, it only represents 8.7 of the overall market, but it's actually one of the fastest growing markets today, is the long construct MIS market. So what does the future hold? I really do believe robotics will be kind of a game changer, and I believe that it'll allow surgeons to actually overcome the gap from doing these multi-level procedures, because I do believe that the robotic technology will allow surgeons to place in percutaneous screws without even having to think about it, to tell you quite honestly. And once the robotics allows the surgeons then to also contour the rod and then also place the rod robotically, I think that's really going to change things quite drastically. I do believe that endoscopic spine surgery is the next step from going from open to tube-based MIS, which I do, and I think the next step is endoscopic spine surgery. And then finally, I do agree with Jens that expandable cages are the future. Expandable cages allow us to actually place in a small implant through a small incision and to expand it into something that's much larger. So that this sort of evolving technology is one that we're really keeping a close eye on. So the future of robotic endoscopic fusions, I mean, you might think that sounds crazy, but I think that's probably the future, where we can probably control the robots endoscopically to have visualization and then perform these even long constructs through percutaneous means. So in summary, MIS deformity correction is difficult and it's got a very steep learning curve. There's no question about that. But some of the benefits of MIS scoliosis surgery is really being validated in the literature today. There's definitely less infection risk, no question about that. Typically lower levels of fusion of levels required using MIS techniques, shorter length of stay, less likely to require ICU stay, and even if you do require ICU stays, they typically tend to be shorter. So adoption of MIS techniques is really good for our patients, and innovation in MIS spine, I believe, is the future. Thank you very much.